Good morning, everyone. When I talked to Lynn about doing this, it occurred to me that talking during lunch is perfect, right? Because nobody will fall asleep if you talk during lunch. After lunch that you get in trouble. So first, let me just say thank you to everyone for being here today. And I'd especially like to thank Lynn Bullock and the Jonathan Foundation for putting this incredible conference together. Kudos to them. And I certainly appreciate the opportunity to be here today to talk to you all a little bit about what the still relatively new Department of Public Health in South Carolina is doing in terms of mental health and suicide prevention efforts, and also talk about some future partnerships that we hope will come from some of the work that we're doing. Now, at the Department of Public Health, we take the issue of mental health very seriously, and we're laser focused on trying to improve the mental health in our state, reduce the risk of suicide, and also we consider substance use issues an important part of mental health, and we focus a lot on that as well. In 2021, coming out of COVID, we knew that our employees were stressed, and we think that an important part of mental health is taking care of your own staff and setting the example. We take a people-first approach to everything we do at the Department of Public Health, and therefore, as we saw the stress coming on our staff from COVID, we partnered with Credible Mind to provide our employees with a no-cost, confidential platform where they can access a large library of information about mental health and wellness resources, and also suicide prevention, and they can get to that 24/7, 365. We've also partnered with the Office of Mental Health and the American Foundation for Suicide Prevention since 2021 to offer what we call Talk Saves Lives suicide prevention education. And that is a mandatory annual education for all of our 2,900 staff at DPH. We provide information about agency mental health and well-being resources to new hires as part of our new employee orientation. And we also provide every new employee with a self-card that provides them with links to our resources as well as crisis hotline numbers if they need them. In 2022, we partnered with the National Council for Mental Well-Being to have a cohort of staff trained as mental health first aid instructors. These instructors provide mental health first aid courses to our staff at no cost, and so far we've trained over 300 members of our staff in mental health first aid, and many of them have had the occasion to use that. Just this year, we've implemented a suicide care pathway policy to provide guidance to our DPH clinic staff on how to screen clients for suicide risk and link them to care. Because we see tens of thousands of patients in our health departments every year, because South Carolina, if you don't know, is a state where the local and county health departments are actually part of the state health department. They work for us. And oftentimes our clients have mental health issues. It can be very difficult to link them to treatment, but being able to identify those who may be at risk of suicide has helped us to prioritize those that we most need to get to treatment and try to work to get them into the treatment system. We also have incredible partnerships, and this is where I think the future lies. It's really working together as a team all across the state to improve substance use, mental health services, and by extension, therefore, hopefully preventing suicide. Most recently, we launched the Suicide Coalition in fall of 2024 as a collaborative between the Department of Public Health, the Jonathan Foundation, who sponsored this conference, and also the Department of Mental Health's PD Mental Health Center. This coalition has had engagement from over 60 community partners, and that has really extended our ability to work to improve the mental health of the community, because we can't do it alone, right? DPH can't do it alone, Office of Mental Health can't do it alone, but when we all work together, we can make progress. The coalition has key representation from our Brighter Days target audience. We also have MUSC Health, the Leatherman Behavioral Care Pavilion, which you just heard about, McLeod Health, Hope Health, Mercy Medicine, Care South, and also Lighthouse Behavioral Health. The Florence School District 1 is another partner, and I think when you heard some about them, they are one of the best school districts in our state for taking care of mental health issues in their students, and we appreciate that. They're really a leader in that field. But we also work with a number of churches, church-based schools, and first responders, very importantly. We've extended representation from our nonprofits serving mental health and civic leaders, so this is truly a community effort. As an agency, we work on suicide prevention in a number of important ways. One thing the Department of Public Health does, as you may have seen from Will's excellent presentation this morning, is we have a lot of data, right? We collect a lot of data. We get all the birth certificates, all the death certificates. We know about most hospital admissions. So there's a lot of data that we get in. But data is only of value if it's put to use to improve the health of the people of South Carolina. So as you saw this morning, we've been doing that. We regulate, we work with a number of different groups to share that data. We collect the data that you saw, we share that data, we have county data, city data, and we meet with local officials in those places. We do what we call data walks, where we put up posters that show the data like you saw this morning in a place like a library or in a community meeting, so that people can see what are the challenges in our community, and then they can try to work to overcome those challenges, and we can help them find resources to do that. Because we know that in the end, the best solutions usually come from the community. So when we give them information and tools, they can then take that and make the changes they need to make in their community to make progress. Another thing that we do, of course, is at DPH, we regulate all inpatient facilities in the state, including mental health facilities. That includes mental health hospitals, residential treatment facilities, and a number of other types of facilities. Substance use treatment facilities are also regulated by us. One of the things that we're working on now is, as part of that, as we revise those regulations, we're asking facilities to give us outcomes data, to show us not just are they following the rules, but are they actually providing high quality care? Are their patients getting better? And we're going to start making that information available to the public so the public can use that to make choices about their care and treatment as well. Because in the end, treatment is only valuable if it helps the person get better. And so we're working very hard to make sure that is the case at all the facilities that we license and regulate. Now, beyond our regulatory role, we have a number of programs which do important work related to mental health. One of those is screening pregnant women and new moms for mental health issues and substance use issues. Because unfortunately, South Carolina has one of the highest rates of maternal mortality in the country. And that means while the woman is pregnant or during the first year after the child is born. And actually what we have found is most of those deaths occur after the child is born. And a majority of those are due to mental health and substance use issues. We have a real problem with access to maternity care in our state and prenatal care. 15 of our 46 counties have no OBGYNs. Another 5 only have 1. And in many of those counties, less than half of women get adequate prenatal care or postnatal care. So one of the things that we've done is the legislature gave us funding this year for a mobile maternity unit. Basically, an OBGYN clinic on wheels that is going to go around to those counties that don't have OBGYNs. And a key component of that, and we've written this into the contract, we're going to contract the service out, is that that unit has to provide mental health and substance use screenings to every patient they see. I think that's going to be incredibly important to make sure that women are being identified who are having mental health issues early so we can help them get the care that they need. We also provide the South Carolina Violent Death Reporting System, which you heard a little bit about this morning. The group that does that has partnered with the Jonathan Foundation and the Brighter Days group to provide key data points for the PD on local suicide data and suicide circumstance data, as you saw from Will. And we can do that in all the other areas of the state as well, and we are working on that. We also supply the data that the Office of Mental Health and serve on their South Carolina Suicide Prevention Coalition and the 988 Suicide and Crisis Lifeline Advisory Board. In 2024, the Office of Mental Health used that data to secure a grant, which is funding efforts to increase access to youth screening and mental health services, a desperate need in our state, raising awareness through social media marketing, and much more. Our group also partners with the South Carolina Law Enforcement Assistance Program to improve suicide data collection for public safety officers, including first responders in the military, to help us better design services for that population. And later this year, We will be releasing a new online dashboard that will include suicide data and circumstances regarding suicide deaths in South Carolina. It will feature data available across the state, region, and county levels in order to make this information more available to the public than it ever has been before. And I also mentioned that we see substance use as a key component of mental health. Jim, in that very kind introduction, mentioned that I'm a psychiatrist. I can tell you I'm one of only 2 psychiatrists who's also a state health officer in the country. The other one's in Hawaii. I keep telling my colleague that South Carolina is better, but he doesn't believe it. But one of the things that I've seen in my own clinical practice is many of my patients have both a mental health and a substance use issue. Unfortunately, in our state in the past, sometimes we haven't recognized that. And that's been a problem. A facility will give you mental health services or they'll give you substance use services, but they won't do both. And therefore, the patients tend not to get better, and that's a real problem. So we're working very hard on that. Some of the things that we're doing in the substance use field. We have what we call the LEON program and the ROLL program. These provide Narcan at no cost to law enforcement agencies and to first responders like paramedics and firefighters, so if they come upon someone who may be having an opioid overdose, they can save their life. Hundreds of doses have already been provided and hundreds of lives saved through those 2 programs. We also provide overdose kits through our health departments. Again, at no cost. Anyone can just walk in and ask for it. You don't have to show identification. You don't have to say why. You just come in and tell us you want one, we give you one. Those include naloxone, the life-saving drug that can reverse a opioid overdose, but they also include, very importantly, fentanyl and xylazine strips. These are test strips. So although we don't want people going out and buying drugs on the internet or doing some of the things that people do, we know they're going to do it. So these kits help them make sure, at least if they think they're taking an Adderall pill so they can study better, it doesn't have fentanyl in it, it doesn't have xylazine in it that they don't know about that's going to kill them. And we've given out thousands of those kits statewide. We also provide overdose data to the state. You may know that you may have seen the overdose data report for our state recently came out. Thank goodness, for the first time in many years, the number of deaths due to overdose went down in South Carolina. But that data comes from our agency, and we're the ones that provide that report. Now, finally, as we celebrate the creation of the new Department of Behavioral Health and Developmental Disabilities, and if you haven't heard, our agency is now about a year old. The Department of Public Health came from what was Department of Health and Environmental Control. We were split into 2 last year by the legislature. I can tell you that's been a really positive move. I think being focused on public health has been very helpful. But this year, the legislature said, our system of care is too fragmented. I think most of us who work in this field know that. So they have now combined, as of about a month ago, what were the departments of mental health, the Department of Alcohol and other substance use issues, and the Department of Disabilities and Special Needs. Those are now all rolled into one Department of Behavioral Health and Developmental Disabilities. We are very much looking forward to working with that new department to overcome some of the fragmentation, some of the problems we've seen in our state in the past, and markedly improve the quality of care that people receive and reduce the impact that mental health and substance use issues are having on our state and its people. Some of the things that we intend to work with that new agency on, and that new agency doesn't have a director yet, but I'm waiting for that person, because the other thing we did is we just moved into a brand new building, the old SCANA, if you know SCANA, the former state electric utility. We just moved into their former headquarters, and we're in there, Department of Public Health, but so is Behavioral Health and Developmental Disabilities. So now, those folks are just down the hall from us. We can work together much more effectively. And what we're working towards as an agency is we hope to have one phone number for all those different services, health department services, substance use services, mental health services. One phone number, provide those services in the same location whenever that's possible. I think in most cases it will be. And one electronic health record, so that when somebody comes in the health department, we can see if they're getting medication for a substance use or a mental health issue, so that we don't prescribe something that conflicts, and that we can coordinate our care more effectively. So we call that the 111 model. One number, one location, one electronic health record, so that people get the help they need when and where they need it, which I think will significantly improve the quality of care we provide in our state. So with that, I think the future is very bright. We talk about brighter futures. I think the future is very bright for the services that we provide and for improving the mental health and of the people of our state and reducing the impact that suicide currently has on our people. So look forward to working with all of you as we continue to make these efforts move forward. And now, no, she's here. I'm supposed to introduce Deborah Blaylock, Deputy Director for the Office of Mental Health's Division of Community Mental Health Services, who's going to provide an overview of her agency. Oh, there she is. Deb, thank you.
Thank you. Hey, everybody. Thank you very much for having me. Thank you, Dr. Simmer. You helped me zip through some of my slides. So y'all don't panic when you see how many slides I have. I go through them very quickly. So strap on, get ready for the ride. All right. So as Dr. Simmer said, we have a new name. Breaking news. The Department of Mental Health is no longer. We're now the Office of Mental Health and this new fabulous big agency. And this is interesting, you may not have known. Previously, DDSN, Department of Disabilities and Special Needs, and DEODIS, you know I always say it wrong, so I'm not even going to try to say what it stands for, but Substance Use Services, they were a part of DMH in the past. So the General Assembly this year decided to put Humpty Dumpty back together again. So yay, we're all together and we're very excited about it. We have a new home, as Dr. Simmer said, big, fancy, beautiful building, very different from what I was used to on Bull Street. So OMH no longer has a presence on Bull Street after 200 years. So that's a big switch for us. Little history, I'm not going into the history because we're going to talk about what's coming. We're going to talk about the present and the future. So as you all know, we have 16 mental health centers, we have 3 hospitals, and as of July 1st, we will have 1 nursing home. The 16 mental health centers cover all 46 counties of our state. Those mental health centers have a total of 58 clinics. And again, I'm zipping through all this. We have currently almost 3,800 employees. We're a large agency before we were merged and consolidated with the other 2 agencies, so OMH is a big office. Just some data about the workforce, a lot of medical staff, as you can see. Just a little bit of analysis of our workforce. And again, I use this PowerPoint for a lot of different reasons, so some of the stuff you guys couldn't care less about, I'm going to zip through it, and I'm going to get to the stuff you will care about. I like to show the unduplicated patient account, and a lot of my data is FY24 data because I don't have the full compilation of FY25 data, but you can take a look at some of it. I like to show the diagnostics. You can see we're obviously serving the state's folks with the most serious mental illnesses, as we should be. We are the safety net for the state. I like to show this one because DMH does have or OMH. Y'all, every time I say a D, somebody yell at me and I'll remember to say O. We are the safety net, so we do have a hardship reduction policy. So if people tell you they can't receive services because they can't afford them, please call me and put me in touch with the person. I want you to call me and put me in touch with the person so I can disavow them of that knowledge, because we do hardship reduction. And that means services go down to $5 for whatever the service is, and we are happy to do a payment plan for a quarter. So whatever a person needs, we're not going to turn anyone away for inability to pay. You can see where our sources of revenue come from. A good chunk from the state, again, because we're the safety net. The rest from contracts, grants, and fee-for-service, and some federal dollars, obviously. So let's talk about the portals of service. A person can get connected to OMH through about 750 spaces across the state. So we are peppered all over the place, as evidenced by this map. This is where our mental health centers look like and which counties they're responsible for. We have one center, the Beckman, that has 7 counties. We have a couple of centers, Lexington, Berkeley, and Greenville, that each have 1 county. These are where our outpatient clinics are, where we have staff outstationed. So we put staff in a lot of schools. We put staff in DSS offices. We have staff in DJJ offices. We have staff in the child advocacy centers, some of them. We have staff in detention centers. We have staff in law enforcement agencies. These are where our current nursing homes are and our hospitals. I like to show this graphic. Some of my staff hate it because it's super duper busy, but the reason I like it is because it shows you that we want to catch the majority of people that we serve with prevention. Always, always, always prevention. And we're going to serve the smallest number of individuals in the highest level of care, which is hospitals, down in the purple at the bottom. Some of the services that are offered in our mental health centers, and I'm going to hit some slides on some of these, so I'm not going to dwell on this. So by far, we serve the majority of people in our outpatient settings in our mental health centers versus our hospitals. Last year, it was, I think 88,000 were served in the mental health centers and like 3,100 were served in the hospitals, the sexually violent predator program, and the nursing homes. This is something super important to us. We can have the best services in the universe behind the door, but if you can't access them, they're worthless. So access is key. So we have standards for our mental health centers. They have to see a person in crisis within 3 hours of the call. They have to offer that appointment. They have to offer an appointment that would occur within 2 days of an urgent request for service. And they have to offer an appointment that would occur within 7 working days for a routine request for service. Most of our mental health centers will tell you to come on down the day you call, and we will open your case that day. That does not mean, and I like to make sure I'm clear on this, that you will see a psychiatrist the day that you call. You will see a mental health professional who's a master's prepared clinician. And if you have anyone that tells you that they haven't been able to get service, or when they call an appointment is longer than 7 days, please call me. I will give you my phone number at the end of this, and I will get to the bottom of it. Last year, 94.4% of all services requested of our mental health center were offered within those timeframes that I mentioned. And I don't know about any of you, but if you call to get specialty care anywhere, it took me about 6 months to get into a neurologist, and it took me about 3 months to get into an orthopedic doctor. So 7 days to get into mental health. I'm going to zip through these. These are our mental health centers. I'd just like you to see them because I don't want you to think that state facilities are crummy, gross, trashy buildings that nobody would want to receive care in. Our buildings are beautiful, they're well maintained, and staff are proud to work in them, and I think patients are proud to receive services from them. Anderson and Coney Pickens, Beckman with the 7 counties, Berkeley with 1 county, Catawba with 3 counties, Charleston with 2. Charleston is our largest. Coastal Empire with 5 counties. Columbia with 2. It's our 3rd largest. Greater Greenville is our 2nd largest, 1 county. Lexington, 1 county. Orangeburg, 3 counties. PD, right here, 3 counties. Santee Wateree, 4 counties. Spartanburg, 3 counties. Tri-County is our smallest mental health center, 3 counties. And Waccamaw, 3 counties. All right, so one of the big things we do is stigma busting. Again, if a person is afraid to receive services, it doesn't matter how great the services are. If they're afraid to come in the door because they're going to lose their job, they're going to be made fun of, they're going to not be able to succeed at school, then services are worthless. So it's incumbent upon all of us in this room and everywhere outside of this room to decrease stigma. So we participate in a lot of parades, a lot of health fairs. We try to go where we're not preaching to the choir. This is preaching to the choir. But going out to a farmer's market is not preaching to the choir. We are a trauma-informed system. We make sure that all of our staff have training regarding that. We have a large department that serves children. We served last year 32,000 children of the 88,000 individuals that we served in the community, so 1/3 of our population are children. And that's important because obviously if you get kids early on, perhaps you can save lives later on. I know one of the breakouts is about Roads of Independence program for young adults. We focus a lot on young adults because many of you know that oftentimes first onset of psychosis is in the young adult age, And so if we can reach young adults before that occurs and maybe stem that tide, fantastic. If we can't, then we can get them and their families engaged in services early on. Just some more info about Roads of Independence. CAFE is a program we have in Spartanburg Mental Health Center for children, and it is a crisis stabilization program, not a program with beds, but a place where families can come instead of going to an ED. School mental health is big for us. We've been in the business since 1993. We're in right now about 626 schools across our state. We are the single largest school mental health provider in the state. Some of the school mental health locations. I'm zipping through this data because you don't care about it, and if you do care about it, you can have it in the PowerPoint. We do some research on our school programs, and we have a program in combination with USC that is the John McGill School Mental Health Initiative, and those are students who are in the mental health track who really want to focus on school mental health. And our own Christian Barnes, he's here in the audience, he's way over there. He developed this program with Dr. Mark Weiss at USC before Christian left us and went to work for Care South. And we're very happy for Care South to have him, but we're sad we don't have him. This is one of the CACs in the state, and this is the only one that is state-operated, Child Advocacy Center, that treats children with sexual abuse, physical abuse, and emotional abuse. We have first episode psychosis programs, FEP programs across 8 of our mental health centers. These, again, are for young adults who are experiencing their first episode of psychosis. Evidence-based model really helps the family understand what's happening to their young loved person and helps the young person understand what's happening to himself or herself. It's a very scary time for families, and we really owe it to families to focus on this very scary time for them and give them all the tools they need to be successful. You can see where some of the FEP programs are. We have another program that's really cool. I hope all of you will take advantage of this. I hate the name. It sounds like a diaper. Yappy. It reminds me of nappy. It is the Youth Access to Psychiatry program. So it's a consultation program where pediatricians can call and talk to a psychiatrist when they're seeing a kid in the pediatrician's office and they want guidance on what to do with medication for kids. And it's free to the user, and we're not getting a ton of calls on this, so I hope folks will take advantage of it. It's across the entire state, and it's for children 0 to 21. This is one of my favorite programs, and we only have it in 2 counties. We have it in Spartanburg, and we have it in Charleston. So it's a street medicine team. In Charleston, it's called Pharmacy. In Spartanburg, it's called SCORE. And it is a very cool program because it goes out into a community that's high crime rates and high health disparity rates, high ED usage rates. And it brings in law enforcement, EMS, mental health, substance use services, hospital services, the FQHC, all come together in a community that's been identified by community leaders. It's only a couple hours a week. In Charleston, they set up fruits and vegetables. The carrot is really the carrot to get people to come to the table. And we hand out information about services. We go knocking on doors, give people bags of turnips. And I can't tell you how the looks I got the first time I was doing this in this community. And they're like, why is this woman handing me a bag of turnips at my door? This is so weird. The first day we did it in Charleston, people were afraid. They don't trust state agencies. They don't trust law enforcement. They don't trust EMS in some communities. And so they wouldn't participate. Now, every Wednesday, 75 to 100 people are at the one in Charleston. And again, it's a minimal investment by agencies, 2 hours a week, and it's just coming out, meeting people, and creating trust. This one's going to have longitudinal effects. It's not a quick fix by any stretch. It's creating trust in communities where there is none. So this universe is changing because of our consolidation with Deotis. I'm super excited about this. As Dr. Simmer mentioned, many people in our situation, 62% of the people that we serve have co-occurring diagnoses, mental illness and substance use disorders. And so one of them is cigarette smoking and tobacco use. And how do we address that? And I know I'm in Florence, so y'all don't throw anything at me, because I know in our state, tobacco was king for a long time, not so much anymore, right? So we have to address all substance use disorders. And tobacco use is still a thing, particularly with our youth and vaping. So anyway, we're addressing that. And not to the degree that we need to, but we are addressing it. Integrating primary care with mental health care and substance use care is paramount to success. Individuals who live with serious and persistent mental illness die 25 years earlier than their counterparts without a serious and persistent mental illness, 25 years earlier. So the better you can bring primary care into the setting with substance use services and mental health services, the better the outcomes for everybody. We have several of our mental health centers, as you can see, who have done that. We have FQHCs embedded in our mental health centers, and we're getting excellent results from this. Imagine how hard it is to live with schizophrenia, and perhaps you also have a substance use disorder. It's hard enough to make it to one door, let alone making it to 3 doors. We are developing ACT teams at 13 of our mental health centers, act as assertive community treatment. These are programs where staff go into people's homes. It could be multiple times a day. It could be multiple times a week. These are for folks who have a serious and persistent mental illness and a diagnosis of a psychotic disorder, and they have high levels of needs. And these interdisciplinary teams include a nurse, a physician, mental health professionals, substance use professionals, care coordinators, peer support specialists, who all go to the home to serve the individual because that person can't make it to a clinic. More about ACT. The CCBHC model of care stands for the Certified Community Behavioral Health Center model of care, and it's about integrated care. And it is all about bringing together primary care, substance use care, mental health care, and veterans care in one location. We have 2 mental health centers that operate on this model of care, the Beckman Mental Health Center and the Spartanburg Mental Health Center. I would love to see this at all 16 centers, and I'm hopeful with our consolidation, we'll be working toward that end. Again, it's really hard for a person, for lots of reasons, transportation not being the least of them, to get to 3 doors. So 1 door is obviously the best. Highway to Hope is a really cool program that we have. We have 16 RVs, recreational vehicles. Every mental health center has one. These RVs function as mental health mobiles. They go out into rural areas of our state, park at different places, different days, and people can come there and get their care instead of coming to the actual clinic and the mental health center. So even though we have clinics in all but 2 of we actually have brick and mortar buildings in all but 2 counties, these RVs can go everywhere. And so like in Charleston, where we started this program, Charleston County is 100 miles long. So if you can't make it to the mental health center west of the Ashley because you live in McClellanville or in Edisto, these RVs go out to those areas and park. So we park in libraries, FQHCs, free clinics, community centers. In one place we park in an art gallery. We park in Family Dollar parking lots. We park in Walmart parking lots. I've been told by Joy J of the Mental Health Association that there's a Family Dollar store every 7 miles across America, so they're a great place for us to park and partner with them. And so we get a lot of folks coming to these RVs that have never sought treatment before, that are living with schizophrenia, which is just so hard for me to believe that they've never sought care before, but distance is distance. This is what our RVs look like. They're really pretty and welcoming, and the project was named by patients. We had a patient contest to name it Highway to Hope. We have a very robust deaf services program. As you can imagine, individuals who are deaf and hard of hearing and also live with a mental illness have a really hard time accessing care. We have housing and homeless programs. We provide rental assistance to the tune of $2.2 million a year to patients that we serve. The problem that we have is we have more money than we have available affordable housing. I'll let that sit for a second. We have more money to pay for rental assistance than we have affordable housing in our state. We have a program called Toward Local Care, and one of the hallmarks of this program is called Home Share. It is foster care for adults who live with a mental illness. It's a very cool program. I call it foster care. It's not officially foster care, but that's what it's like. So the community member agrees to take a person, one of our patients, into his or her home, integrate them into the family. We pay them a stipend to do that, and the person lives with them, just like a family member. We have a great partnership with Voc Rehab for supportive employment. We use an evidence-based model called individual placement and support. We have IPS at all of our mental health centers. And the beautiful thing about IPS is the tenet is we don't care where you are in your recovery. We don't care how stable you are. We don't care about any of that. Do you want to work? That's what we care about. Do you want to work? And what kind of work do you want to do? We don't think everybody who lives with a mental illness just needs to work in janitorial or food industry. So what kind of work do you want to do? I want to be an astronaut. Okay, well, that might not be attainable, but what intrigues you about being an astronaut? Why would you want to be an astronaut? Is it being outdoors? Is it science? Is it exploring things? What intrigues you? And then we try to match people with jobs, and we have job coaches who go with them on site if they so desire. Very successful program, probably the hallmark program for recovery in our system. We've won quite a few national awards for our program in South Carolina. I'll just zip through that. Peer support is something that we can't do without. I'm a really good therapist, but there are people that I cannot meet who won't talk to me, who don't trust me, who don't like me, who don't want to listen to what I have to say. I don't live with a mental illness. I don't have any experience with living with a mental illness. Peer support specialists can encourage someone to talk to me and trust me and believe in me that I can help them. In the law enforcement space and the first responder space in general, critical. I'm married to a retired law enforcement person, and I can promise you he would have never talked to me as a therapist, never, ever, ever, and I thought he probably wouldn't even do it now, and I've been married to the dude for 20 years. But peer support can connect people to care, because first responders are going to trust another first responder, and they're not going to trust me unless a first responder says you can trust Debbie. True? Joe now? True? True. Okay. We love peer support. We need more of it. We need to hire more. We have money to hire more. I need more. Anybody who wants to be a peer support specialist who meets qualifications, please see me. We have a very robust Office of Suicide Prevention. Jesse Barnes is going to present to you on that in the next session. And as was mentioned earlier, we host the Coalition for South Carolina for Suicide Prevention. And Jesse and her team, we're going to have to change it because it can't be the Office of Suicide Prevention and the Office of Mental Health, so we're coming up with a new name. But anyhow, that team has done lots of hard work around South Carolina in terms of training. We use all evidence-based models to train. We train anybody, anywhere, anytime. Hospital systems, lay people, churches, community members, Rotary clubs, you name it. If they raise their hand and want training, we're going to go train. They brought the Zero Suicide program to South Carolina. Many of our hospitals now use that model of care. DMH, obviously, OMH. Oh, I need a jar to drop a quarter in every time I say D. OMH uses Zero Suicide at our hospitals and our mental health centers. And some of the actions that South Carolina, and I say South Carolina, not OMH, has taken to address suicide prevention. Because as Dr. Summer said, we're all in this together. No one agency can do anything alone. We all have to be partners in it. And you can see some of the legislative actions that a lot of folks in this room have worked on. Elizabeth Harmon from the Hospital Association, I saw you somewhere, and other folks have worked on to get this legislation passed. So I want to talk about the crisis continuum really, really quickly that we operate at OMH. 2 years ago, we started the second call center in the state for 988. Mental Health America, I'm so grateful to Mental Health America, Greenville County, for operating the first call center in the state for decades. It wasn't 988 at the time. It was the Suicide Prevention Lifeline. Now we all know it as 988. And we knew we needed to start a second call center in our state. Nationally, every state is recommended to have at least 2 call centers for obvious reasons, particularly if you live on the coast, right? One goes down, you have the other one. Interestingly, in South Carolina, Greenville went down, but we luckily had Charleston up because Greenville went down with Helene and lost power for a long time. So we were fortunate to still have a second call center. So we started the second call center in June of 23. And before that call center started, 58% of the calls that emanated in South Carolina were answered in South Carolina. I'm very proud to report to you that now 89% of the calls that emanate in South Carolina are answered in South Carolina. So that is huge for our state because somebody in Wyoming does not know the resources in South Carolina, right? So just some data about the call center. And the latest I saw this morning from the call center in Charleston, to date, they've answered 27,000 calls in 2 years. We have the mobile crisis team, which has been spoken about earlier in the day. So mobile crisis is our crisis response team. All 16 mental health centers have it, covers all 46 counties. And I'm very happy to report to you that this year the General Assembly appropriated some more money to us to create second teams in some of our counties. So that is great news because if one team is out and a call comes in for another deployment out into the field, they would have to wait till the first call is resolved for the team to be able to go to the second call. So to have a second team in some of our counties will be super helpful. We also operate the Mobile Crisis Call Center that answers all the calls for mobile crisis. That's located in Charleston in a building that they're co-located to the 988 call center. I know you can't see this data, but I'm a data freak. I love data. It helps me decide where we need to put our resources, and it helps our state decide where to put resources. So this just is some data about calls that came in FY24. And I really like to look at the response of calls, response time, if we do have to deploy out into the community, because we don't always have to deploy. Sometimes the call center can manage the calls. So this data that you're looking at now shows the average length of time it took for a team to respond to first responders. This is critically important to first responders. So they can't sit out there and wait all day for us to get there. They have other things to do. So our average time for response, in-person response, was 48 minutes across all 46 counties. The national standard is 60 minutes. In urban areas, 2 hours, in rural areas, and 3 hours in territories, and we did it 48 minutes across all counties of South Carolina. We do some really cool things with telehealth in mobile crisis, so we can do a telehealth assessment with law enforcement and EMS. We started this with EMS in Charleston in 2017, and now we're rolling it out across the state with law enforcement as well. So they don't have to wait for us at all. They just have to pop up a program on their phone that we pay for the licenses for them to have, and then we can HIPAA approved assess them through the product on the phone and help law enforcement determine what to do with them, or EMS. Just some data about that project, but a very cool thing about it, 58% of the people that we assessed in the first year of this program were diverted from an ED. So as you all know, in South Carolina, EMS can only transport to an ED. Has to be a hospital. So 58% were diverted. They didn't have to go anywhere as a result of this project. We embed clinicians and EDs around the state, and it's a cost share with certain EDs, and you can see where they are. We have currently, I'll say 1.5 crisis stabilization centers. So we have one in Charleston that's a 10-bed facility co-located with the Alcohol and Drug Services Facility Authority in Charleston County. We have one in Spartanburg, but it doesn't have a bed capacity, so don't really classify it strictly as a crisis stabilization unit. And we are opening a second one in Richland County any day. We're just waiting. Where's Dr. Simmer? We're waiting for DPH to give us our license to get it open. This is what it looks like, the one in Charleston. Ligature-resistant furniture, as you can see, very pretty, light, open, welcoming. It's a place for law enforcement to drop off individuals, individuals to self-refer, other providers to refer, and just some of the data related to it. The average length of stay is 3.2 days. And this is the Eubank Center, the one in Spartanburg. It's a pure living room model, again, no beds. We pay for individuals who are indigent to go to hospitals around the state if they need a hospital stay. Why do we do that? Because we don't have enough beds to accommodate all these individuals, for one reason. Another reason is people are better served if they're in their own community. Their families can participate in their care if they're hospitalized in their own community. And not everybody needs a long state hospital bed stay. So 13 hospitals are on the QPL, and you can see where they are. All right, I'm going to zip. A lot of you already heard about justice-involved programming that we have. So we embed in law enforcement, we embed in detention centers, we have mental health courts, just some of the data about that. We do a lot of patient satisfaction. We have a division of medical affairs. We have a huge telepsychiatry program, covers 27 hospitals. Been doing it for a very long time. Telepsych's a big deal for us because there are a lot of communities that don't have psychiatrists. We have transition specialists that really focus on getting somebody out of a hospital and into the community, care coordination, and we do all the things you would hope and expect us to do, like quality assurance, corporate compliance, credentialing, blah, blah, blah. I'll skip all that. And these are our hospitals. You might be interested in this piece, like where they are, how many beds they have in terms of functional beds versus licensed beds. So that data is up there on the screen for you. Some of the length of stay for our hospitals. Our forensic services is a mandated function that we provide, and that is making sure that individuals who aren't competent to stand trial get restored or found not restorable to stand trial. We run Morse Village, which is the alcohol and drug hospital, and some info about that. And you don't care about that stuff. I'm zipping through it. We do a lot of grants. We have lots of grants, $155 million worth of grants currently. That's a lot of grants. We have 187 facilities, buildings around the state. One thing that was mentioned earlier, I just want to hit on this really fast, is alternative transportation. So alternative transportation is if a person's going from an ED to a psychiatric facility. In the past, they could only be transported by law enforcement, family, if they so chose, or EMS. DMH was given some money to contract with another provider to provide transportation, and it's a secured vehicle. It's statewide. All 46 counties have it. It's adults only, not kids. So mobile crisis does not transport, but alternative transportation does, but it's from an ED to a hospital. Some data about that. And then the last thing that you may not be aware of is that we respond to a lot of disasters across the state. And to other states, we spent a lot of time, 2 weeks in North Carolina after Helene this fall. But we respond to Emmanuel, we responded to the Townville shooting, we responded to the Sofa Superstore fire, to all the floods, to the Graniteville train wreck, and some other things. So I want you to know that your community mental health centers go where they're asked to go. We don't just show up, but we're here for the long haul. So, you know, with a lot of times with natural disasters or man-made disasters, folks fly in from all over the state, and as soon as the cameras are gone, they're gone. OMH is not ever going to be gone. So if there's something going on, we're going to be present for it if we're invited to come. And that is it. Oh, Dr. Simmer did mention Credible Minds. We pay for Credible Minds for the whole state of South Carolina. Now I can't get back to it. Maybe you'll cut me off because I'm talking too long. But if you're interested in it, there is a piece, the slide right before this one, that shows that as a resource. So please take advantage of it. And thank you all very much.